Today we'll discuss diabetes insipidus. First, don't confuse diabetes insipidus with diabetes mellitus. Diabetes mellitus is a disorder of glucose metabolism. Diabetes insipidus is a disorder of water balance caused by problems with antidiuretic hormone, ADH, or the kidney's response to it. The word, insipidus, means tasteless, referring to the urine, unlike diabetes mellitus where the urine contains glucose and tastes sweet historically. Key physiological changes. Diabetes insipidus increases plasma osmolality and decreases urine osmolality. Let's understand why. 1. Plasma osmolality increases. Normally, ADH helps the kidneys reabsorb water. Water returns to the bloodstream. Blood remains diluted. In DI, ADH is absent or ineffective. Water cannot be reabsorbed. Large amounts of water are lost in urine. As water leaves the body, blood becomes more concentrated. Sodium concentration rises. Therefore, plasma osmolality increases. Think of making soup. If water evaporates while the salt stays, the soup becomes saltier. Exactly the same happens in the blood. 2. Urine osmolality decreases. Since the kidneys cannot concentrate urine, water remains inside the tubules. Huge volumes of dilute urine are produced. Therefore, urine osmolality decreases, meaning the urine contains very little dissolved material compared with the amount of water. Definition. The slide defines diabetes insipidus as production of large volumes, more than 3 liters per 24 hours, of dilute urine, urine osmolality less than 300 mosm per kilogram, due to deficiency of or insensitivity to antidiuretic hormone. Let's analyze every part. Large urine volume. Normally, adults produce about 1 to 2 liters per day. In DI, more than 3 liters per day. Severe cases may produce 10 to 20 liters per day. This is called polyuria. Dilute urine. Urine osmolality is less than 300 mosm per kilogram, meaning the kidneys fail to concentrate urine. Normally, urine can reach 800–200 mosm per kilogram under the effect of ADH. Cause. The underlying problem is either not enough ADH is produced, or the kidneys don't respond to ADH. Either way, less water is reabsorbed. Types and mechanisms of diabetes insipidus. The slide lists 4 types. 1. Cranial, central, diabetes insipidus. The most common type. Mechanism. The brain does not produce enough ADH. Remember, ADH is produced in the hypothalamus, stored and released by the posterior pituitary gland. Damage to either area causes central diabetes insipidus. 2. Nephrogenic diabetes insipidus. Here, ADH levels are normal, or even elevated. The problem is, the kidneys cannot respond to ADH. Think of it this way. The hormone knocks on the kidney's door, but the kidney refuses to open it. 3. Primary polydipsia, dipsogenic diabetes insipidus. This isn't a true ADH deficiency. The main problem is, the patient drinks excessive amounts of water due to an abnormal thirst mechanism. Because they drink so much, plasma osmolality falls. ADH secretion is suppressed. Large amounts of dilute urine are produced. Examples. Psychiatric disorders, psychogenic polydipsia. Hypothalamic lesions affecting the thirst center. 4. Gestational diabetes insipidus. This occurs during pregnancy. The placenta produces an enzyme called vasopressinase, which breaks down maternal ADH. As a result, ADH levels become insufficient. The mother develops polyuria and polydipsia. This usually appears in the 2nd or 3rd trimester. Resolves after delivery. Common symptoms of DI. Because patients lose a lot of water, they develop polyuria, large urine volume. Polydipsia, excessive thirst. Nocturia, frequent nighttime urination. Dehydration if water intake is inadequate. Hypernatremia in severe cases. Diagnosis of diabetes insipidus. When a patient presents with polyuria, excessive urination, and polydipsia, excessive thirst, we should not immediately diagnose diabetes insipidus. The diagnosis is made in a logical sequence. Step 1. Rule out other causes of polyuria. Many diseases and medications can produce excessive urine. These must be excluded first. A. Drugs. Some medications increase urine output. Examples include diuretics. Increase sodium and water excretion. Most common cause of medication-induced polyuria. Lithium. Can damage the kidney's response to ADH. Causes nephrogenic diabetes insipidus. Caffeine. Mild diuretic effect. Increases urine production. Alcohol. Suppresses ADH secretion. Less ADH leads to more water loss. B. Diseases. Other illnesses can also cause polyuria. Diabetes mellitus. High blood glucose exceeds the renal threshold. Glucose remains in urine. Water follows glucose by osmosis. This is called osmotic diuresis. Heart failure. Patients may urinate more after lying down at night because fluid from swollen legs returns to the circulation and is filtered by the kidneys. This is called nocturnal diuresis. Renal failure. Damaged kidneys lose their ability to concentrate urine. Large amounts of dilute urine may be produced, especially early in chronic kidney disease. C. Electrolyte and endocrine disorders. Hypercalcemia. High calcium interferes with ADH action. Produces nephrogenic DI-like symptoms. Hyperthyroidism. Increases renal blood flow and urine production. Hypokalemia. Low potassium decreases kidney responsiveness to ADH. Can produce nephrogenic diabetes insipidus. Step 2. Confirm polyuria. Measure a 24-hour urine output. This confirms whether the patient truly has polyuria. Normal urine output is less than 3 liters per day. Polyuria. More than 3 liters per day. Remember, patients often say, "I'm urinating a lot." Always measure objectively. Step 3. Initial laboratory tests. Now we investigate whether the urine and blood findings fit diabetes insipidus. Plasma osmolality. High plasma osmolality is more than 305 mosm per kilogram. Serum sodium is usually more than 145 mmol/L. This is called hypernatremia. Again, water loss exceeds sodium loss. Urine osmolality is less than 200 mosm per kilogram. This is extremely dilute urine. Urinary sodium. Usually 20 to 60 mmol per liter. This is not the key diagnostic finding but provides additional information. Urine-specific gravity. In diabetes insipidus it becomes less than 1.005, meaning the urine is almost pure water. Step 4. Confirmatory test. The gold standard is water deprivation test. This test evaluates whether the patient can concentrate urine when deprived of water. Principle. Normally, if a healthy person stops drinking water, the following events happen in sequence. Plasma osmolality rises. ADH secretion increases. Kidneys reabsorb water. Urine becomes concentrated. In DI. This mechanism fails. Procedure. The patient is deprived of fluids for up to 8 hours or until 5% body weight loss occurs. This test must be done under close medical supervision because severe dehydration can develop. Then, desmopressin 2 micrograms IM is administered. Now we observe how the urine responds. Interpretation. There are 3 possibilities. 1. Primary polydipsia. Initially, during water deprivation, the patient begins producing concentrated urine without desmopressin. Why? Their ADH system is intact. The only problem was excessive water intake suppressing endogenous ADH. Once water is restricted, ADH is released normally. The kidneys respond. Urine osmolality rises. Therefore, diabetes insipidus is ruled out. Diagnosis. Primary polydipsia. 2. Central diabetes insipidus. Initially, during water deprivation, urine remains dilute. Plasma osmolality rises. This shows insufficient endogenous ADH. Now desmopressin is given. Since the kidneys are normal, they respond immediately. Results. Urine osmolality increases markedly. Plasma osmolality falls toward normal. Urine volume decreases. This confirms central diabetes insipidus. Key point. The kidneys work, they just needed ADH. 3. Nephrogenic diabetes insipidus. Initially, water deprivation does not concentrate the urine. Then, desmopressin is administered. Nothing changes. Why? Because the kidneys are resistant to ADH. Even synthetic ADH cannot stimulate water reabsorption. Results. Urine remains dilute. Plasma osmolality stays elevated. No significant increase in urine osmolality. Diagnosis. Nephrogenic diabetes insipidus. Key point. ADH is present, but the kidneys cannot respond. Step 5. Imaging. CT scan or MRI of the head. This is done after central diabetes insipidus is diagnosed. The purpose is to identify structural causes of ADH deficiency. MRI is generally preferred because it provides better visualization of the hypothalamus and posterior pituitary. Comparison of central diabetes insipidus and nephrogenic diabetes insipidus. Although both diseases present with polyuria, polydipsia, high plasma osmolality, hypernatremia, dilute urine, the underlying problem is completely different. Think of ADH as a key and the kidney as a lock. In central diabetes insipidus, there is no key because of ADH deficiency. In nephrogenic diabetes insipidus, the lock is broken because of kidney resistance. 1. Definition. Central diabetes insipidus. Here, the body does not produce enough ADH. Without ADH, the kidneys cannot reabsorb water. Nephrogenic diabetes insipidus. Here, there is insensitivity to ADH despite normal or high levels. ADH is present. Sometimes the body even produces more ADH because plasma osmolality is high. However, the kidneys cannot respond. 2. Cause. Central diabetes insipidus. In conditions that may damage either the hypothalamus, where ADH is synthesized, or the posterior pituitary, where ADH is stored and released. Such as trauma. Head injury may damage the pituitary stalk or hypothalamus. Neurosurgery. Operations near the pituitary gland can accidentally disrupt ADH production or release. Pituitary tumors. Tumors may compress or destroy the posterior pituitary. Examples: pituitary adenoma, craniopharyngioma infection, meningitis, encephalitis. These can inflame the hypothalamic pituitary region. Stroke. Reduced blood supply may damage the hypothalamus or pituitary. Nephrogenic diabetes insipidus. In conditions such as genetic mutations. Examples: V2 receptor mutation, aquaporin 2 mutation. These prevent the kidney from responding to ADH. Lithium toxicity. This is the most common acquired cause of nephrogenic diabetes insipidus. Lithium enters collecting duct cells and interferes with ADH signaling. Hypercalcemia. High calcium impairs the kidney's ability to respond to ADH. Hypokalemia. Low potassium also reduces the kidney's concentrating ability. Tubulointerstitial disease. Diseases affecting the renal tubules damage the site where ADH normally acts. 3. ADH levels. Central diabetes insipidus. There is low or absent ADH. Why? Because the pituitary cannot release enough ADH. Simple. No hormone. Nephrogenic diabetes insipidus. There is normal to high ADH. Why? The hypothalamus senses dehydration. It keeps releasing ADH. But the kidneys ignore it. Therefore, ADH accumulates in the circulation. 4. Plasma osmolality. Both types show high plasma osmolality, more than 305 mosm per kilogram. This finding cannot differentiate the two diseases. 5. Serum sodium. Both show Elevated serum sodium, more than 145 mmol/L. Again. Water is lost. Sodium becomes concentrated. Result. Hypernatremia. This also does not differentiate the two diseases. 6. Urine osmolality. Both show low urine osmolality, less than 200 mosm per kilogram. Since water is not reabsorbed, urine remains very dilute. Again. This is common to both types. 7. Water deprivation test. In both types, the urine initially remains dilute because water cannot be conserved properly. The key difference appears after giving desmopressin. Central diabetes insipidus responds to desmopressin with an increase in urine osmolality. Nephrogenic diabetes insipidus. No significant response to desmopressin. 8. Treatment. We will discuss this in a minute when we talk about management of DI. But let us now ask ourselves, in cases of suspected diabetes insipidus, what is the most appropriate next investigation? In suspected diabetes insipidus, the most appropriate next investigation is urine and plasma osmolality. This is the non-invasive first step. This means that when a patient presents with symptoms suggesting diabetes insipidus, the first laboratory investigation is not the water deprivation test. Instead, we begin with a simple, non-invasive tests which are plasma osmolality, urine osmolality. These tests provide important clues before moving to more specialized investigations. Why do we measure osmolality? First, remember the definition of osmolality. Osmolality is a measure of the concentration of dissolved particles known as solutes in a fluid. High osmolality equals concentrated fluid, less water, more solutes. Low osmolality equals dilute fluid, more water, fewer solutes. In DI, the problem is loss of free water, so the blood and urine change in opposite directions. Plasma osmolality. In diabetes insipidus, ADH is absent as in central type or ineffective as in nephrogenic type. The kidneys cannot reabsorb water. Large amounts of water are lost in the urine. As water leaves the bloodstream, the blood becomes more concentrated. Sodium concentration increases. Plasma osmolality increases. Typical finding. Plasma osmolality is more than 305 mosm per kilogram. Urine osmolality. Normally, ADH allows the kidneys to concentrate urine by reabsorbing water. In DI, water remains in the renal tubules. The kidneys produce large amounts of dilute urine. Therefore, urine osmolality is low, less than 200 mosm per kilogram. What happens after these tests? Suppose a patient has polyuria and polydipsia. You order plasma osmolality and urine osmolality. Scenario 1. High plasma osmolality plus low urine osmolality. This strongly suggests diabetes insipidus. The next step is the water deprivation test with desmopressin to differentiate. Central diabetes insipidus. Nephrogenic diabetes insipidus. Primary polydipsia. Scenario 2. Normal or low plasma osmolality. This makes diabetes insipidus less likely. The clinician should consider other causes of polyuria, such as diabetes mellitus, excessive water intake, primary polydipsia, diuretic use, hypercalcemia, chronic kidney disease. Management of diabetes insipidus. The treatment of DI depends on the underlying cause. 1. Central diabetes insipidus. Primary treatment. Desmopressin is the drug of choice because it is a synthetic analog of ADH. Mechanism of action. Normally, ADH binds to V2 receptors in the collecting ducts. This activates adenylate cyclase. And aquaporin 2 channels move to the luminal membrane. So, water is reabsorbed. And urine becomes concentrated. Desmopressin performs exactly the same function. Dosage. Oral tablets 100 to 200 micrograms 2 to 3 times daily. This is commonly used for long-term treatment. Intranasal spray 10 to 20 micrograms per spray. Advantages. Rapid absorption. Higher bioavailability than oral tablets. Sublingual tablets 120 micrograms 3 times daily. Useful for patients who prefer not to swallow tablets. IV or IM 1 to 4 micrograms per day. Used in hospitalized patients. Severe dehydration. Patients unable to take oral medication. Additional management. Encourage drinking only when thirsty. Why? Desmopressin greatly reduces urine production. If the patient drinks excessive water while taking desmopressin, water will accumulate. Hyponatremia develops. And water intoxication may occur. Therefore, patients should drink according to thirst, not force excessive fluid intake. Adjust water intake. The goal is to maintain normal hydration. Avoid dehydration, fluid overload, hyponatremia. 2. Nephrogenic diabetes insipidus. This is the most interesting part because desmopressin does not work. Why? Because the kidneys are resistant to ADH. Treatment therefore aims to reduce urine volume, remove the underlying cause, improve renal response. Primary treatments. A. Thiazide diuretics. Example: hydrochlorothiazide 25 to 50 mg per day. Why give a diuretic to someone already producing too much urine? This is a classic exam question. It works through a paradoxical antidiuretic effect. Mechanism: thiazides block sodium reabsorption in the distal convoluted tubule. So, mild sodium loss occurs. And extracellular fluid volume decreases slightly. The proximal tubule compensates by reabsorbing more sodium and water. So, less water reaches the collecting ducts. And overall urine volume decreases. So, although thiazides are diuretics in healthy people, they reduce polyuria in nephrogenic diabetes insipidus. B. Amiloride. Dose: 5 to 10 mg per day. This drug is especially important in lithium-induced nephrogenic diabetes insipidus. Mechanism: lithium enters collecting duct cells through the epithelial sodium channel. Amiloride blocks these channels. So, lithium cannot enter the cells. And further damage is prevented. This is why amiloride is the preferred drug for lithium-induced nephrogenic diabetes insipidus. CNSAIDs. Example: indomethacin 50 to 100 mg per day. Mechanism: normally, prostaglandins reduce ADH action. NSAIDs inhibit prostaglandin synthesis. So, remaining ADH works more effectively. And urine volume decreases. NSAIDs are usually used as adjunctive therapy, not alone, because of their potential gastrointestinal, renal, and cardiovascular adverse effects. Additional management: stop offending drugs. Example: lithium. If possible, stopping lithium improves nephrogenic diabetes insipidus. Also correct reversible causes such as hypercalcemia and hypokalemia. Limit salt and protein intake. Low salt diet, less sodium intake, will lead to less sodium filtered by the kidneys. So, less water excreted. And urine volume is reduced. Low protein diet, less protein, will lead to less urea production. This will lower renal solute load. And obligatory water excretion will be reduced. So, there will be less polyuria. 3. Gestational diabetes insipidus. Primary treatment: desmopressin. Why? During pregnancy, the placenta produces vasopressinase. This enzyme destroys natural ADH. However, desmopressin is resistant to degradation by vasopressinase, making it effective. The dose is individualized, using the same formulations and general dosing ranges as in central diabetes insipidus. Additional management: avoid if due to a defective thirst mechanism to prevent water intoxication. Explanation: if the patient's thirst mechanism is impaired, adiposic diabetes insipidus, they may not regulate water intake appropriately. Giving desmopressin without careful monitoring can lead to excessive water retention and hyponatremia. These patients require careful supervision of fluid intake and serum sodium. 4. Dipsogenic DI, primary polydipsia. Remember, this is not true diabetes insipidus. The patient drinks excessive water. So their ADH secretion is suppressed. and large amounts of dilute urine are produced. Primary treatment. No specific pharmacologic treatment. Why? Because the kidneys and ADH system are normal. The problem is behavioral or due to an abnormal thirst mechanism, not hormone deficiency. Giving desmopressin could be dangerous because it promotes water retention while the patient continues drinking excessively, increasing the risk of hyponatremia. Additional management. Behavioral strategies include limiting excessive water intake, treating underlying psychiatric disorders if present, educating the patient about appropriate fluid intake,